Good evening. So today we are going to discuss a small topic, osteoarthritis. So osteoarthritis is a disorder that affecting our joint. This is the image. This is our healthy joint. This is a joint consists of two bones, and at the end of bones there is a protective cartilage. This blue color indicates a protective cartilage that provides a cushion-like effect in this joint and helps for the smooth movement. So this blue color indicates protective cartilage. So this osteoarthritis, it occurs when after a few years, this protective cartilage wears off. This will wears down so that there will be a friction between these two bones and some cracks are formed. This is known as osteoarthritis. It is the damage of that protective cartilage. Thereby, some cracks are produced, and it is characterized by severe pain in the joint. During and after movement, there will be pain. That is known as osteoarthritis. So, this is a disease that affecting our joint. And there is another diseases, rheumatoid arthritis and gout. These diseases you will be discussed in recorded videos. Okay, that these portions you should cover from recorded videos. Here we will discuss osteoarthritis only. So this rheumatoid arthritis is actually an autoimmune disorder. Autoimmune disorder means our own immune system will attack the cells of this joint. This joint cells will be affected by our own immune system that leads to severe inflammation. That is rheumatoid arthritis. It is an autoimmune disorder and characterized by severe inflammation of the joint. Okay, you will be studied in recorded videos in detail. So osteoarthritis, it occurs when the protective cartilage that cushions the ends of bone wears down over time. It takes few years. After that, that protective cartilage will wears down. That leads to osteoarthritis. And this disorder commonly affects joints in hands, knees, hips, and spine. And the symptoms include severe pain. Okay, during and after movement, there will be severe pain. Then stiffness. Stiffness is noticeable upon awakening or after being inactive. The patient, if being inactive for some times, then start to move, then there will be stiffness and pain. Then swelling and tenderness of the joint, then loss of flexibility. There will be difficulty in movement. That is known as loss of flexibility. These are the symptoms of osteoarthritis. So now we will see the treatment. Whenever a patient is suffering, experiencing pain in the joint and he is consulting a doctor, initially he will not recommend any medication or surgery. Initially, they will ask for some lifestyle modification. Okay, it is the first step, lifestyle modification. The physician, the doctor will educate the patient, then give advice. Then he will advise some exercises. Okay, throughout the treatment, exercise should be followed. Some strengthening exercise, then aerobic fitness exercise. Then if the patient is obese, he will suggest weight loss also. Okay, these are the first step, lifestyle modification. Then if the pain does not subside, the doctor will suggest first line analgesic drugs. First line analgesics, that is paracetamol. Okay? So this paracetamol, acetaminophen is important. Mostly the question will ask regarding paracetamol. What is the first line analgesic used in osteoarthritis? That is paracetamol. Then topical NSAID gel can also be used in elderly patients and all. Topical NSAID gel is also used as the first line analgesia. And again, if the pain does not subside after taking paracetamol, then we will consider second line analgesics, that is NSAIDs, then COX-2, selective COX-2 inhibitors, then opioids. In case of severe pain, opioids are considered, then topical capsaicin. Along with this second line analgesics, the doctor will suggest some supportive therapy like the use of assistive devices, use of foot orthotics, then supports and braces can be used. Okay, these supportive therapy can be considered. And surgery is only the last step. Okay, after lifestyle modification, exercises and paracetamol and second line analgesic, even the pain does not subside, then we can consider surgery. Now we will see the treatment in detail. Okay, mostly the question regarding paracetamol will ask, but you should understand this also. So initially, in case of mild osteoarthritis, the doctor will encourage regular exercise throughout the treatment. So in case of mild osteoarthritis, the doctor will suggest regular exercise. He will encourage regular exercise throughout the treatment. Then if the patient is obese, he will suggest weight loss. Then physical therapy, land and water based exercises like swimming and all, okay, will be effective. It is the first step, that is lifestyle modification. In case of mild osteoarthritis, lifestyle modification will be advised. In second step, we will start the treatment with medication. That is, which is the first line first line agent used in osteoarthritis?
Acetaminophen.
Yes, acetaminophen. We will consider acetaminophen. If the pain does not subside, it is not effective, the patient is not responding to acetaminophen, then we can consider NSAIDs like ibuprofen, naproxen can be considered. Okay. Again, if the pain persists there, then we can consider combination of glucosamine and chondroitin. It is a combination of glucosamine and chondroitin that help for the regeneration of that protective cartilage. Regeneration of protective cartilage. And when we are giving combination of glucosamine and chondroitin, we should monitor the patient for 3 months. If this combination is effective, we can continue after 3 months. If it is not effective, the pain still remain there, then we should discontinue this combination. We should monitor for a period of 3 months. Okay, after that, if it is effective, we can continue. Otherwise, we should discontinue. So third one is combination of glucosamine and chondroitin. Next, we will consider opioid therapy. Okay, opioids, we know that opioids are analgesics we can use for severe pain. In case of cancer pain and all, in case of severe pain, we will consider opioid therapy. And when we are giving opioids like methadone, oxycodone, we should monitor properly. Okay, these drugs have high abusive potential. Okay, dependence can be produced. So it should be properly monitored. Then next option is corticosteroid injection. Corticosteroid injection can be used for acute exacerbation of knee osteoarthritis. Acute exacerbation. Corticosteroid injection can be considered only for acute exacerbation. That means for temporary relief only. We cannot use corticosteroid injection continuously. We know that. This corticosteroid injection have so many side effects. It may cause cartilage erosion also. Further cartilage erosion can also happen. So many adverse effects are there for corticosteroid injection. So we can use for the temporary relief only. Cannot use it for the repeated use. That is corticosteroid injection. Next one is hyaluronic acid injection. Hyaluronic acid injection is considered in case of persistent knee osteoarthritis. If there is a persistent pain in knee osteoarthritis, we can consider hyaluronic acid injection. It will produce a lubricating effect in the joint. Okay, in osteoarthritis, there will be damage of the protective cartilage. There will be some friction between bones. When we are using hyaluronic acid, a lubricating effect will be produced and helps for the smooth movement. That is the mechanism of hyaluronic acid injection. So we started from acetaminophen. till hyaluronic acid injection. Okay. In some patients, after using these all methods, even after that, the pain persists. Then the final step, the last step is surgery. That is replacement surgery. Knee replacement, hip replacement, like that. At last, I say last step, we will consider replacement surgery. So you should know these steps, everything, understand. You should understand that. Next question. So a question regarding comes from this chapter. An 88-year-old frail woman with osteoarthritis has difficulty in walking and pain. She has no other medical history and has failed numerous aids to help her with the pain. Which of the following drug is the best recommendation? Option A, acetaminophen. Option B, glucosamine D. Option C, celecoxib. Option D, ibuprofen. So this patient has osteoarthritis, difficulty in walking and pain. She has no medical history. She has failed numerous aids. That means she did some initial methods like exercise and all. Okay, that done, but there is no effect. Okay, that does not help her to overcome her pain. So in this step, which drug we can consider? The patient does not taking any medication till now. She just is starting her treatment. She did
Acetaminophen.
Then so yes, in this step we should consider acetaminophen. Okay, most of the some students are also choosing this answer. Okay, here they are indicated here mentioning that the patient has used numerous aids, means some supportive treatments like exercise, weight loss and
before taking the medicine.
Before taking the medicines, she did exercise and all. Okay, but she that doesn't help her to overcome her pain. Now she is starting his first line therapy with acetaminophen. The remaining rheumatoid arthritis and gout, you should study from recorded videos. Okay, we can expect 1 or 2 or 3. Mostly from rheumatoid arthritis, more questions will ask. From gout and this osteoarthritis, 1 or 2 questions we can expect. Okay. So now we will discuss some questions. First one, an elderly patient suffering from depression was given St. John's wort. Which of the following drug, if administered concomitantly, will have a clinically significant interaction? So here an elderly patient suffering from depression. For that she is taking St. John's wort. And along with that, if among this drug, if administered concomitantly, will have clinically significant interaction. Option A, simvastatin. Option B, salbutamol. Option C, citralline. Option D, gliclazide.
C.
Yes, option C, citralline. So here, the patient is suffering from depression. This St. John's wort is a herbal drug. Okay, this is also another question. What is the indication of St. John's wort? This is a herbal remedy we are using for the treatment of depression. So in depression, which neurotransmitter is involved in depression? Okay, serotonin. Okay, when you say serotonin, okay, in depression is a disorder, is a CNS disorder in which the serotonin level will be very low. Serotonin is a neurotransmitter that is responsible for our mood, that controls our mood. In depression, serotonin level will be very low. Okay. So when this patient taking St. John's wort, this serotonin level get increased, so that we getting the effect in depression. Okay, the mood will elevated, happy mood will come. Okay, so that is the mechanism. In depression, serotonin level will be low. When taking St. John's wort, this serotonin level will get increased, so that we get the treatment, relief of depression. That is the mechanism. Then this citralline belongs to which class?
Antidepressant.
It is also antidepressant medication, selective
etc. Right.
serotonin reuptake inhibitor. Again, if the patient take this medication, it is a selective serotonin reuptake inhibitor that also increase serotonin level. This drug, St. John's wort, will increase serotonin level. Again, sertraline will increase serotonin level. There will be a dangerous increase in the serotonin level in patient. That is known as serotonin syndrome. Okay. So that is the interaction between sertraline and St. John's wort. So we cannot take together. There will be severe dangerous interaction that is known as serotonin syndrome. Next question. A 35-year-old individual is receiving 20 mg of propranolol hydrochloride 4 times daily as a prophylaxis to migraine attack. If the drug has only 25% bioavailability due to extensive first-pass effect, what amount of the drug reaches to systemic circulation after each dose? So here, the patient is taking 20 mg propranolol. So here, another point is there. For the migraine attack, prophylaxis of the migraine attack, we will take propranolol. Okay, propranolol we are taking for the prophylaxis. Okay, prevention. For the prophylaxis of migraine attack, we can take propranolol. Here the patient is taking 20 mg propranolol. And also another point, propranolol is highly prone to first-pass metabolism. Okay, what is first-pass metabolism? I think you studied in general pharmacology. Before entering into systemic circulation and producing effect, first the drug will go into liver and a portion of that drug will be metabolized there. Only a small portion. Only a small portion, remaining portion will enters into systemic circulation. That is known as first-pass effect. Here, this propranolol is a drug we are using for the prophylaxis of migraine attack, and also it is highly prone to first-pass effect. It is a drug which extensively undergo first-pass metabolism. So, 25. So, the drug has only 25% bioavailability. We are taking 20 mg drug, but only 25% bioavailability is there. 20%. 20 mg drug we are taking, only 25% of that enters into systemic circulation. So how much? What is the amount of drug that reaches into systemic circulation? That is the question. 20 mg we are taking, only 25% of that enters into systemic circulation. We are taking 20 mg drug, but the bioavailability is only 25%. What do you mean by bioavailability? The amount of the drug that reaches into systemic circulation. We are taking 20 mg, but bioavailability is only 25%. Only 25% of the drug enters into systemic circulation. 25% means what? 20 into 25 divided by 100. 5. Okay, only 5 mg is enters into systemic circulation. We are taking 20 mg propranolol, but after first pass effect, only 5 mg is enters into systemic circulation. Clear? Okay. It is a simple calculation. Okay. Next question, what is the appropriate recommendation for diclofenac oral tablet use? Option A, with food or milk to decrease GI upset. Option B, take with fatty meals to enhance absorption. Option C, 2 hours after meals to avoid delay in absorption. Option D, 4 hours before meals to prevent drug-food interaction. A. Yes, option A is right. So diclofenac is a NSAID drug. On prolonged use, mostly after prolonged use, there will be chances of GI bleeding, GI ulcers. So in order to prevent that, we should take diclofenac along with food or milk to decrease GI upset. So mostly the case is discussing in case of long-term use, prolonged use. Okay. In prolonged use, there are chances of GI bleeding, ulcers, GI irritation and all. So in order to Avoid that. We should take diclofenac along with food or milk. Next question. The pharmacy received a call from intensive care unit nurse who has a patient receiving intravenous solution containing amoxicillin. The doctor ordered morphine to be injected into the Y site of the intravenous solution every 4 hours. The nurse wants to know if these drugs will be compatible at the Y site, from which references the pharmacist should provide the required information. So here a patient is receiving IV amoxicillin. Now the doctor ordered to administer IV morphine also. So the nurse wants to know if there is any interaction between these two, IV amoxicillin and IV morphine, whether they are compatible or not. Okay. So from which book we can give advice for that nurse? That is the question. Option A, Red Book. Option B, Merck Manual. Option C, Review of Natural Product. Option D, Handbook on Injectable Drugs.
Is it D?
Yes, Handbook on, from the name we can understand that Handbook on Injectable Drugs. These drugs we can use to refer when we are administering two intravenous solutions together, if there is any interaction or compatibility, if they are compatible or not. If we mix some solutions together, there are chances of precipitation or their pharmacological activity may lose. Okay. For that reference, we can use Handbook on Injectable Drugs. This Red Book mostly pricing of drugs. Okay, it consists of pricing of drugs. Okay. Then Merck Manual, it consists of a detailed prescription of diseases. What are the signs and symptoms, and which is the first line drug, and which is the second line drug, what is the mechanism of that drug, what is the side effect, like all the detailed information about the disease and drug is contained in Merck Manual. Next is a review of natural products. So it consists of natural drug remedies. That is review of natural products. Next question, which of the following laxative has the slowest onset of action? Option A, psyllium. Option B, glycerin. Option C, bisacodyl. Option D, milk of magnesium. Which laxative has slowest onset of action? Option A, psyllium is the answer. So psyllium, it takes about 12 to 72 hours to produce its action. When we take psyllium, it takes about 12 to 72 hours to produce its laxative action. So it has slowest onset of action. And glycerin, if we use glycerin suppository and all, the action will be produced within 1 hour. Then bisacodyl, gerbisa. Okay, that is bisacodyl. Okay, it is a OTC medication. If we are taking at night at bedtime, it will produce the laxative action within 6 to 12 hours mostly. The action will be produced. Milk of magnesium means magnesium hydroxide. It will produce action within 1 to 6 hours. So which one has slowest onset of action? That is psyllium. It takes about 50 to 72 hours to produce its action. So one more point. This magnesium hydroxide, milk of magnesia, what is the side effect of magnesium hydroxide? The common side effect of magnesium hydroxide?
I'm not sure.
Okay. So this magnesium hydroxide and aluminum hydroxide, these both are antacids. Okay, these both are systemic antacids. You will study in GIT chapter. Magnesium hydroxide and aluminum hydroxide are antacids we are using for the treatment of constipation. Only magnesium hydroxide. Okay, magnesium hydroxide will produce side effect is diarrhea. Diarrhea. Okay. Aluminum hydroxide side effect is constipation. Okay, these are major side effect. Magnesium hydroxide and aluminum hydroxides are antacids. And when we use magnesium hydroxide, it will produce diarrhea as a side effect. When we use aluminum hydroxide, it will produce constipation. So generally, we are giving a combination of magnesium hydroxide and aluminum hydroxide. To counteract their effect, we are giving a combination of them as antacid. Okay. Next question. A 25-year-old woman with a history of migraine is associated with aura has taken tablet ergotamine. 2 mg sublingual at the first sign of migraine, then 2 mg every 30 minutes as needed. What is the maximum number of ergotamine tablet that can use in 1 week? The question is, what is the maximum number of ergotamine tablet that she can use in 1 week? So we already discussed that. Which drug is used for the prophylaxis of migraine? Prophylaxis of migraine, which drug is used? We discussed as propranolol. Propranolol is used for the prophylaxis of migraine. Here for the treatment, we will take, for the treatment of migraine, we will take ergotamine. Okay, when taking ergotamine, the dose, the number of tablet is very important. This will produce a serious side effect that is known as ergotism. So ergotamine will produce a serious side effect that is ergotism. Ergotism means vasospasm that leads to ischemia. There will be spasm, that is constriction of our blood vessels that leads to ischemia. The oxygen distribution of our body may get affected. Okay. So when we give ergotamine, we should monitor the dose and number of tablets. It is very important. What is the side effect of ergotamine?
Ergotamine side effect.
Ergotamine will produce
Nausea.
Ergotism. Okay.
Okay.
Ergotamine will produce a serious side effect that is known as ergotism. Ergotism means vasospasm. Vasospasm that leads to ischemia. Oxygen distribution in our body get affected. So while we are giving ergotamine, we should properly monitor its dosing. Okay. So you should note down the point. The maximum dose of ergotamine per day is 6 mg per day. Okay, this is the maximum dose of ergotamine that we can take in a day, 6 mg. This is a guideline. It is a fixed value. You should study like that. Okay, 6 mg. It is a constant value, 6 mg per day. 1 day we can take maximum 6 mg. And per week we can take 10 mg. 10 mg per week. It is a maximum dose we can take per week, that is 10 mg. Understand? So you should study these 2 points, 6 mg per day, 10 mg per week. So here the question is, what is the maximum number of ergotamine tablet that she can use in 1 week? In 1 week, we can take maximum 10 mg. The available tablet dose is 2 mg. Commercially, ergotamine 2 mg tablets are available. So divided by 2, 5 tablets can take per week. In a week, maximum 5 tablets can be taken. So per day, how many tablets can be taken maximum? 6 by 2 is equal to 3 tablets. Okay. Next question. So this is a case type question. So recently for DH exam, most questions are based on lab values. Okay, they will give a story like question. At the end of that, there will be some lab values, and based on that lab values, they will ask questions. Also, some interaction based questions. Okay, there will be a large question. Okay, one page question. It will be time consuming. You should thoroughly read that questions, and maybe some hints will be there. Based on that, you should answer that. So the thing is that you should study the recorded videos, pharmacology and non-pharmacology in thorough. The pharmacology is our basics. We should study the interaction, major side effect, like everything should study properly. So here a question, a 60-year-old man with chronic kidney disease for 5 years hypertension, coronary artery disease, diabetes mellitus is due for routine follow-up. Test result, result normal values are given. Sodium, the value is 140. Normal range is 134 to 146. So sodium is in normal range. Next is potassium. The value is 4. Normal range is 3.5 to 5.1. So this is also in normal range. Chloride 100. Normal range is 97 to 108. So this is normal. Bicarbonate 22. Normal range 21 to 25. Okay. Calcium 2.5. Normal range 2.15 to 2.62. Calcium ionized 1.2. Normal range 1.1 to 1.3. That is also normal. Then phosphate inorganic 2.5. Normal range 0.8 to 1.51. The value of phosphate is increased, elevated value. Okay, others are normal. So the level of phosphate is elevated. That is known as hyperphosphatemia. The question is, which of the following drug is most appropriate? If from this lab value, we should understand that the phosphate level is more. The patient is suffering hyperphosphatemia. So in order to treat hyperphosphatemia, which drug can be given? Option A, sevelamer. Option B, calcium acetate. Option C, calcium carbonate. Option D, aluminum bicarbonate. For hyperphosphatemia, we will use sevelamer. Sevelamer. Hyperphosphatemia, sevelamer. Hyperphosphatemia, note down. Hyperphosphatemia, that is sevelamer is used. In hyperkalemia, which drug is used? Hyperkalemia. Okay, in hyperkalemia, we will use kyaxalate. Okay, I think we already discussed in toxicology. Okay, hyperkalemia, we will use kyaxalate. Next question. A 73-year-old woman has a 3-week history of weight loss, heat intolerance, palpitation, and tachycardia. On examination, she is anxious and warm extremities. She is not fit for available ablative therapy and doctor wants to try medication instead. See the lab result. So thyroid stimulating hormone TSH value is 0.12. Normal range is 0.4 to 5. 0.4 to 5. That means the value is low. Okay. The result is 0.12. Normal range is 0.4 to 5. That means the value, 0. TSH. Okay. Value is 0.12. The normal range is 0.4 to 5. So the value of TSH is low value. Low. Okay. Low. 0.12. Here 0.4 to 5. So the value is low. Then T4. The value is, result is 25. Normal range is 8.5 to 15.2. That means T4 level is very high. So the question is, what would be the best initial choice of drug? So from this lab value, we should you should identify what is the condition of patient. TSH level is low and T4 is high. What is the condition? Hyperthyroidism or hypothyroidism? Hyper. Okay. T4 level is high and TSH is low. That means hyperthyroidism. Hyper. So in hyper, which drug we will use? Methimazole. Carbimazole, methimazole, propyl thiouresil. That means, so methimazole we can choose. In case of hypothyroidism, which drug can we choose? Levothyroxine. Okay, like that you should choose the answer. Next question. The following lab results are from a 35-year-old woman who is being treated for reflux esophagitis. So, sodium 138, normal range 134 to 146. So, it is okay. Then potassium 4, normal range 3.5 to 5.1. That is also normal. Then chloride 100, normal range 97 to 108. That is okay. Then bicarbonate 22, normal range 21 to 28. That is also okay. Then calcium 2.2, normal range 2.15 to 2.62. That is okay. Then calcium ionized, that is also okay. Then magnesium. Okay, magnesium 0.4. Normal range 0.7 to 1.2. So magnesium level is low. Magnesium level is low. That is known as hypomagnesemia. Hypomagnesemia. So the question is, which of the following drug would have contributed to the abnormality in this lab result? Which drug is responsible for the hypomagnesemia? Option A, omeprazole. Option B, cimetidine. Option C, ranitidine. Option D, gaviscon. So we can simply find the answer. That is, omeprazole has a side effect of hypomagnesemia. So the patient, they also given a clue. The patient is being treated for reflux esophagitis. The patient is being treated for reflux esophagitis. Here we will give mostly proton pump inhibitor. For the treatment of reflux esophagitis, we will give proton pump inhibitors like omeprazole, pantoprazole. As a result, the patient is taking omeprazole. As a result of that, side effect of that, hypomagnesemia is produced. This omeprazole is produce electrolyte imbalance in our blood. For example, hypomagnesemia. Okay, simply you should study omeprazole. Side effect is hypomagnesemia. Thank you.